etiologies, and then we'll have our case presentation. So neonatal seizures are a frequent manifestation of neonatal neurological disease, and the incidence varies with gestational age and birth weight, with a higher incidence in very low birth weight infants. Neonatal seizures differ from those in older children and adults, both clinically and how we treat them, as well as EEG patterns. And the recognition of neonatal seizures can be difficult because subclinical seizures are common, and so EEG monitoring is critical in the identification of neonatal seizures, as well as understanding whether our treatments are effective. Treatment of neonatal seizures is necessary as animal models and human studies indicate secondary brain injury from seizures can lead to worse neurobehavioral outcomes. A seizure is an excessive synchronous depolarization of neurons within the central nervous system. And this may occur due to an imbalance of excitation over inhibition in the brain. Neurological injury that disrupts this balance can bring about this in the newborn brain through a couple of ways. Hypoxia, ischemia, or hypoglycemia, for example, can lead to failure of the ATP-dependent sodium-potassium pump, which destabilizes the cellular membrane potential. Excess release of the excitatory neurotransmitter glutamate due to hypoxia ischemia can result in excessive depolarization. And in the normal developing immature brain, excitatory receptors are relatively overexpressed because this fosters synaptogenesis. Brain injury accentuates this imbalance of excitation over inhibition. The inhibitory neurotransmitter GABA is lower in the normal newborn brain and may be paradoxically excitatory due to reversal in chloride ion gradient compared to the adult brain. And because these receptors are more excitatory than inhibitory, our GABA agonist medications that we use to treat seizures may contribute to the seizures actually being more refractory. Metabolic abnormalities that alter the membrane potential, such as hypocalcemia or hypomagnesemia, or genetic conditions such as pyridoxine dependency that affect the production of GABA are also mechanisms of seizure development in neonates. Brain injury from neonatal seizures can be divided into mechanisms related to prolonged seizures versus frequent or recurrent seizures. Early life seizures cause less neuronal death than those seen in older patients, but have significant effects on synaptic function and network development. Prolonged seizures may lead to hypoventilation and apnea, which leads to hypoxemia, contributing to ischemic injury in the brain, which then potentiates this. Changes in cerebral blood flow with seizures, in particular, disruption to gestational age-dependent autoregulation can also contribute to brain injury. Progressive depletion of cellular energy substrates such as ATP and phosphocreatine can also lead to brain injury. And severe seizures lead to excessive synaptic release and impaired synaptic reuptake of glutamate. Recurrent frequent seizures result in long-term cognitive deficits, in particular visual spatial memory and learning, thought to be because of the particular vulnerability of the hippocampus. Recurrent seizures alter network function, and so does this rather than the cellular loss that contributes to the neurocognitive deficits that are seen. And seizures can result in long-term alterations in neurotransmitter receptors with this persistent abnormal balance between excitation and inhibition, and increases in other excitatory neurotransmitters such as AMPA or NMDA, and overall decreases long-term in GABA. The American Clinical Neurophysiology Society and the International League Against Epilepsy have developed a framework of describing and defining neonatal seizures. Electrographic seizures are a paroxysmal abnormality in cortical electrical activity that evolves in morphology, frequency, and location on the EEG. And these have a minimum amplitude of 2 microvolts and last 10 seconds or more. When evolving patterns are shorter than 10 seconds, they are referred to as brief rhythmic discharges, and by the ILAE criteria are also classified as seizures. If no clinical changes correlate with the EEG, this is referred to as EEG only, subclinical, non-convulsive, or occult seizures. Electroclinical seizures involve an EEG-confirmed seizure that is temporally associated with a clinical alteration, such as a change in behavior or respiration, or motor manifestations. Because of the importance of matching clinical signs with an EEG pattern and the high occurrence of EEG-only seizures in neonates, continuous video EEG monitoring is the gold standard for diagnosis of neonatal seizures. In clinical situations where this is not available, the ILAE task force stated that amplitude integrated EEG can be useful, but that clinical observation alone is not sufficient for diagnosis. By this 2021 classification, electroclinical seizures can be classified into motor, non-motor, sequential seizures, where there is a progression or a change in the type of seizure, or unclassified. And the seizure type can evolve over time, which is why the recommendation is that the classification of a type of seizure is based on the predominant clinical signs. Clinical recognition and inter-rater agreement for all seizure types is low, but better for automatisms and spasms than other motor types. Electrographic seizures, as I mentioned, are based on EEG patterns only and are very common and can be seen after anti-seizure treatment due to electroclinical dissociation, which we'll touch on later. Numerous studies have indicated that about 70 to 90% of electrographic seizures in newborns do not have associated clinical correlate and would not be identified without EEG monitoring. So that's a range, but some of that number is quite large. Other studies have shown that EEG confirmed seizures only have clinical changes about 10 to 20% of the time. And other studies have shown that experienced clinical staff have limitations in correctly identifying clinical changes as seizures in babies. Taking a look at the types of seizures in the motor seizures category, these are classified into automatism, such as lip smacking, tonic deviation of the eyes, sustained eye opening or eye deviation, and bicycling as examples. These are also known as subtle seizures and are more common in preterm than in term infants. Apnea in term infants associated with subtle clinical phenomena is also more likely to be a seizure than apnea in preterms. Subtle clinical phenomena and studies have varied rates of EEG correlation, but are more likely to represent seizure if the newborn has had other seizure types identified as well. In most neonatal seizures, focal or one region of onset is seen. Generalization to both hemispheres of seizure activity occurs rarely in neonates than in older children and adults due to immaturity of brain networks and decreased myelination that would allow the spread of activity through both hemispheres, and this is why the term bilateral is used in this classification. In neonates with electroclinical seizures, the administration of an anti-seizure medication may terminate the clinical signs while the EEG pattern persists. This is referred to as electromechanical coupling or dissociation. And this leads to suppression of the clinical manifestations despite the seizures persisting in the brain activity on EEG. The mechanism of this lies in the high levels of chloride in the neonatal neuron and the mismatch of expression between two types of chloride channels, and KCC1, which directs chloride influx, and KCC2, which restricts chloride efflux. The GABA activation from anti-seizure medications results in chloride efflux and depolarization or excitation. Also, since GABA is excitatory rather than inhibitory in neonatal neurons, GABA anti-seizure medications are less inhibitory and less effective in terminating seizures in more mature brains. Due to the distribution of chloride transporters in the brainstem and spinal cord, the levels of chloride may normalize faster, leading to cessation of the motor manifestations, while cortical seizures will continue without clinical signs. Recent studies, such as those published by the Neonatal Seizure Registry Group, have confirmed that seizure manifestations, or semiology, can shed light on the cause of the seizures, allowing for early identification and possibly directing further treatment or workup. Tonic activity is non-suppressible, brief, rapid phase contraction of a muscle. It's rhythmic and repetitive, and usually focal or multifocal. These can be seen in neonatal focal strokes or metabolic encephalopathies and may not involve alteration in consciousness. Tonic seizures are defined as sustained flexion or extension of axial or appendicular muscle groups, and they are generally associated with genetic epilepsy, with specifically channelopathies to be considered. Myoclonus is defined as rapid, isolated jerking of one or more muscle groups, and can be ictal or non-ictal and potentially even benign in infants. This too can be focal, multifocal, or bilateral symmetrical or asymmetric. And myoclonic seizures may be seen with severe neonatal epilepsy syndromes. But non-epileptic movements are common, and they're important to distinguish from motor seizures. Jitteriness or tremulousness, which may look like clonus, is often associated with HIE, hypocalcemia, hypoglycemia, and drug withdrawal. These are differentiated from seizure by the absence of ocular phenomena or autonomic phenomena. It's often stimulus sensitive, and it can look like tremor and be suppressed. Non-epileptic myoclonus is very common in neonates. In particular, healthy preterm infants can demonstrate spontaneous myoclonus. And term infants may have benign neonatal myoclonus, most prominent in sleep. This can be differentiated from abnormal or pathological myoclonus by arousing the infant and generally does not involve the face. Most neonatal seizures occur with acute presentation of neurological disorders and are considered acute symptomatic seizures, which occur around the timing of insult to the brain. HIE is the most common cause of neonatal seizures, accounting for about 50% of cases of neonatal seizures. Studies have indicated that EEG-only seizures may occur in up to 50% of newborns with HIE, and up to a third of those experience status epilepticus. And a high proportion, over 50% of seizures in HIE in some studies, are subclinical. The seizures generally have their onset from 12 to 24 hours after birth. Studies examining resource utilization for continuous EEG where it's not readily available has shown that the initial 24 hours after birth in patients with HIE provides the highest yield for seizure identification. But longer EEG monitoring is recommended for those with accompanying abnormal background features. Ischemic stroke is the second most common cause of neonatal seizures and accounting up for 20% of cases. When perinatal stroke presents in the newborn period, seizures are the most common sign, presenting in half of patients which are ultimately diagnosed with ischemic stroke. These seizures are most commonly focal and tend to occur after the first 12 hours of life, close to 24 hours of life in some studies. With these patients, there is a high risk of the development of future epilepsy, with up to 50% of cases of neonatal stroke with seizures developing post-neonatal epilepsy over the first decade of life. Intracranial hemorrhage is another important cause of acute symptomatic neonatal seizures, including subarachnoid and subdural hemorrhage, and it accounts for about 15% of seizures at terms. And intraventricular hemorrhage is the most common cause of seizures in the preterm neonate, with the highest incidence of the seizure occurring 24 to 72 hours of life. Intracranial infections, such as group B strep, E. coli meningitis, or torch infections, account for up to 4% of neonatal seizures, and these generally occur in the first 3 days of life, or HSV encephalitis seizures may occur after 7 days. Cerebral dysgenesis or malformations such as lissencephaly, tuberous sclerosis complex, and schizencephaly may not present with their seizures in the neonatal period, but do account for 4% of cases. Transient metabolic disturbances such as hypoglycemia and hypocalcemia account for 4%, and more rare inborn errors of metabolism such as organic acidemias, mitochondrial diseases, pyridoxine-dependent epilepsy account for another 3%. Many of these are very rare conditions, and this excellent figure shows some of them to consider within this rare group. It's important to highlight how seizures differ in preterm infants, as well as to emphasize that past studies have shown that seizures are more common in preterm infants than in terms. Many of these studies, however, like earlier studies on the epidemiology and semiology of neonatal seizures, had varied inclusion criteria and did not always include gold standard EEG monitoring. Also, many studies of preterm seizures were based on clinical observation or amplitude integrated EEG. As we've noted, the most common cause of seizures in preterms is high-grade intraventricular hemorrhage. They may have a later time of onset in preterms than in terms. Clonic and myoclonic seizures are seen but must be differentiated from our common non-epileptic myoclonus that preterms can have. Anapnea is less commonly a seizure type in preterm infants, especially when there are no other accompanying features. Technical and physical limitations of gold standard EEG monitoring make EEG challenging in preterms. ICU artifacts, head size of babies, and skin integrity are all challenges in monitoring our sickest preemies. Neonatal epilepsy presents in the newborn period, although as we have reviewed, is less common. And it can be classified into two main groups. There are a number of neonatal epilepsy syndromes where specific diagnoses can be made based on the age of onset, the background EEG findings, the types of seizures, and ultimately genetic testing. Self-limited neonatal epilepsies are formerly known as benign epilepsies, where are likely to resolve spontaneously or are well controlled with medication and often result in a normal neurodevelopmental outcome. Our developmental and epileptic encephalopathies are where seizures and developmental impairment are related to the underlying etiology, most often presenting with refractory seizures. And infantile forms of these developmental epileptic encephalopathies are those that present before the 3 months of age and often in the NICU. This classification combines the two severe neonatal epilepsies of Ohtahara syndrome, or early infantile epileptic encephalopathy, with early myoclonic epilepsy or encephalopathy. In these conditions, the EEG is grossly abnormal, often has burst suppression, and the seizures are very hard to control. Listed here in this figure are some of the important syndromes to be aware of, especially since some are particularly responsive to a targeted treatment, namely KCNQ2 infantile epilepsies, which have response to sodium channel blocking anti-seizure medications such as carbamazepine, and pyridoxine-dependent developmental epileptic encephalopathy, in which many forms are responsive to pyridoxine. The diagnostic pathway of the cause of neonatal seizures first rests on a thorough prenatal and perinatal history and intrapartum history examining causes of neonatal encephalopathy. Also, a thorough physical examination looking for features of neurocutaneous syndromes or dysmorphisms, as well as a neurological evaluation. Our typical infectious and metabolic screening tests are important early on in our diagnostic pathway. And as we've mentioned over and over, continuous EEG monitoring to understand seizure burden and EEG background, as well as assess the effects of our treatment, is recommended. The success of treatment, as we've discussed, cannot be measured clinically alone due to the high rate of subclinical seizures in neonates. MRI is the recommended modality of neuroimaging with greater yield than ultrasound or CT scan for ischemic changes, malformations of cortical development, and other findings. And finally, second-tier metabolic testing for inborn errors of metabolism, suggested by antepartum seizures, refractory seizures, burst suppression EEG, progressive clinical deterioration, or encephalopathy without a history of HIE, or suggestive of HIE, is performed in concert with genetic testing. So acute treatment of seizures and status epilepticus is a large topic and could be its own lecture. So I wanted to shift gears a little bit and talk a little bit about the question of how to approach maintenance therapy after acute neonatal seizures. So continuance of phenobarbital for months or years was a prior practice with the thought that recurrence of seizure in most patients was likely and suppression of epileptogenic activity was beneficial and would prevent the development of epilepsy. Because of concerns about sedation in infants or the possible neurotoxicity of anti-seizure medications such as phenobarbital, there has developed a variability regarding the timing and approach to discontinuing anti-seizure medications. Recent studies have shown that early discontinuation of phenobarbital may not worsen long-term outcomes. The optimal duration of anti-seizure medication is related to the likelihood of seizure recurrence, which is dependent on the underlying cause of presentation. For example, much more likely in our neonatal epilepsy than in acute hypocalcemia. In multicenter studies, it has been shown that more patients with neonatal seizures due to stroke or intracranial hemorrhage were more frequently continued on long-term anti-seizure medications upon discharge from the NICU compared to those with HIE. Animal studies have shown apoptosis and neurodegeneration with administration of some commonly used anti-seizure medications, as well as an increased risk of later cognitive or childhood cognitive impairments when exposed to some anti-seizure medications, including phenobarbital, phenytoin, and benzodiazepines. Other studies have shown a benefit of some anti-seizure medications, with levetiracetam having demonstrated an anti-epileptogenic effect in animal studies, or levetiracetam antopyramate having a neuroprotective effect in HIE specifically. A review by the WHO recommends the consideration of weaning an anti-seizure medication after 72 hours of treatment if the EEG and the neurological examination are normal and reassuring. And a guideline from this body, the Newborn Brain Society, has concluded that it is a safe approach to discontinue phenobarbital after acute seizures resolve and before hospital discharge in newborns with HIE treated with hypothermia. There's an interesting study of multimodal interventions with NICU nurses focusing on continuous EEG use, which demonstrated, as you might imagine, improved seizure diagnosis in babies, but also led to a decrease in the proportion of newborns that were discharged in anti-seizure medications. So continuing medication requires a risk-benefit analysis regarding the duration of anti-seizure use period. And again, this harkens back to etiology, the extent of neuroimaging injury evident, and EEG abnormalities, as well as the neurological examination. This highlights the importance of continued and longitudinal follow-up for patients with neonatal seizures, as well as having an approach beginning in the NICU to counseling families on the future risk of certain types of seizures, such as infantile spasms, in the highest risk patients. Spend just a couple of last minutes. I think I kind of ran right through this, so we'll have extra time for discussion and case thoughts. But I want to talk about prognosis and outcome, which, as we've said, are most importantly related to the underlying cause of acute presentation of seizures. And this has been a particular interest of mine as a pediatric epileptologist who follows these babies for epilepsy once discharged from the NICU. Studies have historically lumped term and preterm infants together or not considered specific etiologies, or have not had extended follow-up periods to understand school age outcomes and beyond. So this is an area of active study. The incidence of neurological sequelae, which generally involve intellectual impairments or cerebral palsy or epilepsy, in all neonatal seizure survivors remains high at up to 35%, and this has not improved over decades. Many of those children, sorry, let me skip that. Overall, neonatal seizures are associated with an increased risk of epilepsy and intellectual disability than with newborns without seizures, controlling for multiple factors, including an underlying etiology of neurological deficit. Studies have more recently shown that seizures with including a high seizure burden, are more associated with extensive structural brain injury on MRI and lowered standardized neurodevelopmental scores, such as on the Bayley scales of infant development in domains of cognition, motor skills, and language. And normal background activity generally has a good outcome, whereas 90% of infants with seizures in the context of an abnormal EEG background for gestational age have an abnormal outcome. Preterm infants have worse outcomes after neonatal seizures. As we have discussed, they're more associated with severe brain injury, such as high-grade intraventricular hemorrhage. The mortality and development of post-neonatal epilepsy and CP occur at twice the frequency in preterms with seizures than in terms with seizures. Preterm infants with seizures in one study had lower social, emotional, and adaptive behavior scores compared to their peers without seizures, even when controlling for gestation and complications of prematurity, such as high-grade IVH, NEC, and ROP. A large study from 2015 estimated that approximately 18% of children with a history of neonatal seizures developed epilepsy, with a majority of cases presenting in the first year of life. Another prospective study showed that 13% of patients with neonatal seizures developed epilepsy by follow-up at a median of 12 months and with a median age of onset of 7 months. Approximately a third of those patients had infantile spasms, and another third had drug-resistant epilepsy. Clinical predictors of poor outcome for epilepsy include abnormal EEG background, the acute seizure burden with 3 days of seizures being quantified as an important duration, and abnormal neuroexam at discharge. Given that seizure burden or duration of seizures over days is associated with an increased risk of epilepsy outcome, early detection and treatment of neonatal seizures is highlighted as an important and potentially modifiable risk factor for the development of epilepsy. And that's what I have on this massive topic, quick and dirty. And I'm going to stop sharing and I'll have Dr. Carusillo take over.
Tiffani, that was amazing. It's really, really good.
Really fast, sorry.
I love having lots of time for discussion at the end. I think that's going to be great.
Good
Looks
afternoon,
good.
everyone. Okay, great. Okay, can I start? Okay. Good afternoon, everyone. As you know, my name is Milagros Carusillo, and I am a pediatric neurologist from Buenos Aires, Argentina. On this occasion, I will be presenting the case corresponding to this unit. The case involves an extremely premature infant who was evaluated by our neurology service at Hospital Italiano de Buenos Aires. The patient was conceived through in vitro fertilization using own gametes. Delivery occurred via cesarean section at 27.6 weeks due to preterm labor unresponsive to uterine inhibitors. Birth weight was 1,200 grams and Apgar scores were 6 and 8 at 1 and 5 minutes respectively. At birth, the patient exhibited spontaneous breathing, but with poor air entry, requiring positive pressure ventilation initiated before the second minute of life. The heart rate remained above 100 beats per minute throughout resuscitation. She had a respiratory arrest. She was admitted to the neonatal intensive care unit due to her clinical condition. And at 48 hours of life, the patient developed hemorrhagic shock secondary to massive alveolar hemorrhage, which was managed with an adrenaline drip. At 28.1 weeks post-conceptional, a neurological evaluation was requested following the detection of a grade 3 intracranial hemorrhage. In the complementary studies, a cranial ultrasound was performed, showing mildly enlarged ventricles measuring 13 and 14 millimeters at the level of both atria. Additionally, heterogeneous echogenic material was observed within the ventricles, finding consistent with a grade 3 intraventricular hemorrhage. Here in the chart, we can see both values of the ventricular index, in pink, left lateral ventricle, and in blue, right lateral ventricle, both values above the 97th centile. On the other hand, here we can see this ultrasound that is a follow-up study performed at 30.1 weeks post-conceptional, 2 weeks after this, and we can see here that the ventricles continue to increase in size. During physical examination, the patient was in an incubator under sedation and analgesia on mechanical ventilation and receiving phototherapy with ocular protection. Neurologically, symmetrical movement of all 4 limbs was observed in response to tactile stimulation with no evidence of resistance to passive mobility. Deep tendon reflex could not be elicited. The motor reflex was incomplete with hand opening and symmetrical arm extension. However, primitive reflex such as palmar and plantar were present. Because of this physical examination and the complementary studies, we decided to continue monitoring with cranial ultrasound and perform a brain MRI with the patient's clinical condition allows. But the thing is that the patient was monitored with an amplitude integrated EEG, which on day 8 showed a pattern consistent with bar suppression, prompting the performance of a standard EEG. And the standard EEG demonstrated a disorganized pattern with abundant paroxysmal activity. But until that point, no clinical seizures had been detected. Therefore, a video EEG was performed with the following results: a disorganized pattern and discontinuous activity, focal paroxysms in the right temporofrontal central region, and rapid diffusion to the left side. Multiple seizures with the right focal onset and variable semiology were recorded. We recorded 3 types of seizures. Type 1, with sequential myoclonic movements in the extremity with electrical activity in the right temporofrontal central region and hemispheric diffusion. Type 2, with myoclonic movements in the right hand with theta range electrical activity in the right temporal frontocentral region and rapid diffusion. Type 3 seizures with adduction and extension of lower limbs with low amplitude electrical activity in the right temporal frontocentral region and diffusion to the left. And in conclusion, a disorganized tracing with multiple right focal onset seizures and semiology that may vary in lateralization, likely influenced by the patient posture. Because of these seizures, we decided to make a loading dose of phenobarbital at 20 milligrams per kilo and maintenance at 5 milligrams per kilo per day. Here we have, let me see, an example of a type 1 seizure. Look at the extremities. With these myoclonic movements. If you want, I can show you again. And I also have an example of a type 2 seizures with myoclonic movement in the right hand with theta range electrical activity. It is really subtle. Let's see it again. Okay, let's continue with presentation. Okay, because of this video EEG with these seizures, we decided to do a follow-up study 48 hours after the first one, and it revealed a severely disorganized and discontinuous baseline tracing with lateral hemispheric polyspike wave paroxysm, both synchronous and asynchronous, followed by voltage attenuation period lasting 15 to 30 seconds, and numerous brief seizures were recorded, characterized by fragmented sequential myoclonius affecting limbs, trunks, or face. And because of these brief seizures, we decided to make a loading dose of levetiracetam at 30 milligrams per kilo and maintenance at 30 milligrams per kilo per day also. And to conclude this clinical case, the clinical evolution was the following. We performed a control video EEG that was discontinuous, asynchronous, and showed symmetrical tracing with frequent paroxysm of spikes, polyspikes, and multifocal slow waves, both synchronous and asynchronous, along with voltage attenuation lasting 5 to 13 seconds, and no seizures were recorded this time. Since this follow-up video EEG showed no clinical or electrical seizures, treatment was maintained with levetiracetam at 30 milligrams per kilo per day and phenobarbital at 5 milligrams per kilo per day. And a brain MRI is pending to be performed when the patient's clinical condition allows. This is because the patient is still at our hospital. And well, that's my case. I hope you liked it. I think that I believe that the most important aspect of this clinical case is to highlight the importance of complementary studies such as video EEG or continued monitoring, and to discuss the treatment of seizures in preterm infants.
Thank you so much, Milagros. I think this is a really great case, and I'm interested to hear from our other presenters what they think about the case. Who wants to go first?
I guess what I think is important to highlight about this is, we tried to kind of touch on this with the overview, is that the seizures are going to arise out of a background that's abnormal for gestational age, which is so hard to kind of characterize in a sick infant and a sick preterm infant, right? So look to me based on that it was even abnormal for gestational age. And I don't know if Dr. Wusthoff has some thoughts, but the movements can look like they're ictal or not ictal, but I would say on the basis of the correlate, right, that you have this abnormal burst of activity, even though a normal preterm EEG may be discontinuous, I think that clues you in that that's actually a seizure.
Yeah, I would agree. I think I didn't see this case before the session, and it's a tough one. I would say
Sorry
that
we didn't do an easy one. That would be
no,
boring, though.
these are the ones that I think are the most interesting to discuss, because I think clinically, preterm babies, the question of who do you screen and when do you treat, are probably some of the toughest questions that we answer for neonatal seizures. And so I agree with Tiffani. I think the first thing is making sure for the preterm babies that the seizure is really a seizure. And that sounds easy. It sounds like a platitude, but in practice, it can be really hard because their EEGs are not like term baby EEGs, and they're certainly not like EEGs for anybody of a different age. And so I think that's the first question. And as Tiffani was alluding to, when you look at those EEG screenshots in and of themselves, if you didn't have a video and you didn't have a clinical correlate, I wouldn't have said those were seizures. You've got high amplitude activity, you've got some sort of sharply contoured waveforms that are intermixed, but that's what preterm brain activity can look like. And it sounds like it was an excessively discontinuous record. It was going, 40 seconds between those bursts, and the bursts are more brief than I would expect for a baby of that age. So an abnormal background, but not necessarily a seizure. And I think that's where we all end up torturing ourselves, is looking at the video and moving the cursor back and forth to try to figure out, did the brain change happen first? And is it always correlated with the movement? Because certainly the last thing you want to do is overtreat just an arousal or a normal movement, which could have also movements and changes on the EEG from arousal. And so then I think, as was alluded to in the case, it's really looking for that consistent correlation. It's not always making the diagnosis from the first one you see or the one-page example, but looking to see over and over again, is this something that's consistent? And that can be a helpful clue about whether or not they're seizures. And then in this case, you get the gratifying response to treatment, which hopefully shows that you were right. But I think particularly if it hadn't gone well, then you're always in that conundrum of how far down the rabbit hole do you want to go? How confident are you that this is an ictal pattern or seizures? Because certainly if you give enough phenobarbital and enough benzodiazepines, you can make all kinds of activity stop, but that doesn't mean that it was a seizure.
Of course.
We
have.
Go ahead, Milagros.
No, we have a section of epilepsy, so we are like all day long checking this. We don't have like a continuum monitoring EEG, but we can do like 2 or 3 times a day a video EEG. So that's how we try to confirm these events.
Yeah, this is relevant to one of the questions in the Q&A, which from somebody says, what about if I don't have access to an EEG? And I think that this is one of the questions I was going to ask, is sort of also related, is you had said at the beginning of your case, Milagros, that you were screening with amplitude integrated. Was that on the basis of the high-grade hemorrhage? And do you do that for all your high-grade hemorrhages? And, of course, then wondering what, from Dr. Wusthof, what's sort of considered the standard of care in that regard?
So I guess, Milagros, what do you do at your institution?
Yeah.
When there are newborns with high risk of having seizures, we use amplitude integrated monitoring to all of them. But I mean, my hospital is a private one here in Argentina, and we don't have a lot of newborns, so we can do it. Like we don't have a lot of patients to do it. Maybe if we have to choose, we will like select the patients that are in more risk to have it, but we do it to all of them. When we see, for example, this patient, we had previously the ultrasound, and because of this, we started monitoring him. And so we have something to think about it.
Yeah, I think that's a very sensible approach. And I think in terms of the standard of care question, it really is a question of resource utilization and what the trade-offs are where you are. I think that if you, for example, were to put every preterm baby on amplitude integrated EEG, you would have a lot of false positives. And you might even be doing more harm than good, because you'll probably be over-treating some newborns where if you got the full EEG, you would find out they weren't actually having seizures, just because overall, most preterm babies are not having seizures. But if you're thinking, well, which preterm babies are at the highest risk, it's going to be the ones who have a grade 3 or 4 IVH, who are or of the younger gestational age. And so this example, I think, nicely illustrates that of at what point do you cross a threshold where you say, yeah, I'm going to go ahead and screen with a tool for seizures. And I think that's a sensible group to screen in, with a high grade IVH and a lower gestational age. And whether you do that with amplitude integrated EEG or continuous EEG, I think depends on where you are. You know, I would not say you necessarily need to transfer every baby who has a grade 3 or 4 IVH to get continuous EEG monitoring. But if you were at a hospital that has it available, you might go straight to that instead of AEG. And then I do think there is more and more standard of care that once you think you do see a seizure, to confirm it with continuous EEG, with full array EEG, wherever that's possible. And sometimes that's not possible. You are in a region where you don't have access to it, but I think that that would be something that's more strongly indicated to use the continuous EEGs, because even if the AEG is really convincing it's a seizure, you're going to want to know whether or not your treatment's working. And that's where EEG, full array EEG might be a better tool.
What about, we have a couple of questions about treatment. You know, one of the questions, Milagros, was for your institution, is a 20 per kilo loading dose of phenobarbital the go-to? And I'm trying to bring some questions together. Another person asked if, you know, something with GABA and the potential excitatory effects in newborns, is it still the first option? So maybe another question, you know, along those lines.
Yeah, between 15 to 20 milligrams per kilo, but we use 20 milligrams per kilo, and we we check the levels, the therapeutic levels in blood, and it was in range, so we maintain that dose. But with phenobarbital, we try to check it. And yes, we use it as a first line in neonatal patients.
Just thought I would share the code in the background here, you know, for people to get attendance. So where I trained, we did 2 10 per kilo loading doses of phenobarb in preemies, you know, sort of spaced out by 6 or 8 hours. Again, is there a standard? Is there a?
Yes, in our hospital, we use that dose.
Dr. Westhoff, what are your thoughts?
Yeah, I would say there's not, you know, there's no randomized controlled trial where anyone compared giving 10 and then waiting and giving another 10. But I do think that there's some data that maybe we can learn from treatment of pediatric status epilepticus and adult status epilepticus, where very understandably, nobody wants to slam a baby or a kid with a sedating medication. And we're all wary of the adverse effects that can come with that. And so there is this tendency for people to give little aliquots of treatment and like hope that that's going to work, and we'll just check in. And I usually describe it as like the snooze button on the alarm of like, I'm just going to give it another couple minutes and maybe it'll get better. And then like it's been 45 minutes and I'm late for work. And so it's like that with seizure treatment, where if you give like a half dose and then you wait a couple hours and you give another half dose, it's easy to fall into that trap of like, oh, wow, it's been a full day and we still haven't gotten these seizures under control. So the data from pediatric status shows that pretty clearly, that if you don't give the full benzo dose the first time, they're much more likely to develop refractory status, and you end up giving more medication in the long run. And so that's sort of the principle that I apply for neonates. I don't think it's the standard of care everywhere, but it influences my practice to say, just give the full 20. Maybe they don't need that much, but I would rather get the seizures under control quickly than to have to keep chasing with extra doses in the subsequent hours.
Can we borrow the snooze button analogy? That is absolutely brilliant.
Absolutely.
I love that.
And the other thing is our patient was on mechanical ventilation in an intensive care unit. So you are allowed to do it because you have everything under control if something happens, you know. That's another thing I think that is important.
Also, there's a question about maintenance phenobarbital, and automatically starting that, or in light of this data that says maybe we don't send kids home on it, do they even need the maintenance? With how long it lasts. What do you guys think about that?
Tiffany, what do you do?
Chime in too.
Yeah.
I don't mean.
Well, and I know Alexa, we're kind of doing the same practice and it's evolved over time, but obviously when I trained, we started maintenance and we were even continuing it out of the hospital for a month or two, right? So I'm not that old, but that was what people were doing. My practice is to just do boluses of medication and not start maintenance. Rarely do we start maintenance at Maine Health. And if needed, check levels to ensure it's therapeutic after time. But we don't even do that frequently, especially in the smaller babies. We know it's long acting. So we don't really follow the levels necessarily. And then most babies are going home unless they have epilepsy off of medications. And I agree, just to weigh in, I agree with hit it hard and fast with like full dose of phenobarb. I know there's a lot of talk about blood pressure, aside from respiratory, in these fragile infants, but a lot of them are on pressors too. So you have some room, and it is a discussion with the neonatologists, but I don't find it's as big a problem as people feel like it might be, in my experience.
Courtney, do you have anything to add to that?
I agree that for me, if I know the cause of the seizures, I know they're acute symptomatic seizures, the goal is to get the baby off of medicines before they go home. Personal preference, I tend to keep them on medicine for at least a couple of days, mostly because I want to make sure the seizures are really controlled before we stop them. I want to have like seizure free for at least 24 hours. And so I'll give at least a couple of days of maintenance medicine before trying to pull it away. But there's not a perfect number that I know of when to stop it.
Right.
But I agree. I think similarly, I'm older, but when I started, babies went home on medicine and were told you're going to stay on medicine for 2 years. Or we'll see you in 6 months at follow up and talk about the medicine. And so that has been, I think, a meaningful change and improvement in kids' care that we're able to, for many of them, stop medicine before they go home.
And we have another question too, that sort of addresses your clinical choice of which medicine, if you're going to start something after you're doing the loading doses, which do you choose? Obviously, this baby was on both phenobarb and levetiracetam. My practice is to try to go just levetiracetam if I have to go something. But what does that sort of jibe with what others are doing?
We use first phenobarbital and then levetiracetam in neo. But that's here in Argentina, and in Argentina it's easier to get phenobarbital at all neonatal intensive care units. That's why sometimes in Argentina it's like easier to get it.
Interesting.
Maybe not in my hospital that is private, but in public health hospital, it's very difficult to get levetiracetam. So we choose phenobarbital.
Yeah.
I don't know, you have a different like situation there, but in Argentina, sometimes it's really difficult.
That's interesting. I would say that what I usually use is whatever worked. So if the seizure stopped with phenobarbital, that's the thing they're going to stay on most immediately. If we end up in a situation where they're on 2 drugs and we're weaning away one at a time, I always want to get rid of the phenobarb first.
Yeah. And this might be a question back to the sort of more the guts of the chapter rather than the case that we had, but this anonymous attendee asks if there's a suspicion of a channelopathy, is it advisable to try carbamazepine as a drug? I don't know, Tiffany, take a stab at that, or Courtney?
Yeah, I think yes. I think that's generally more accepted practice now that there's been more data to support that that's effective. So it's reasonable to try it early on. If this, like we highlighted semiology, right? There are particular semiologies like tonic seizures that are, sort of migratory clonic seizures that might point you toward a channelopathy. Certainly in my practice, we've tried it earlier.
Yeah, it's the one exception in the ILAE treatment guideline. For everybody, phenobarbital is the first line drug that's recommended unless you suspect one of these channelopathies. In practice, unless there's a family history, it's rare that you know at the time you're giving the first drug, but every now and then you might have that unusual circumstance where you know.
Perfect. There's also a question here about a terminology question about understanding the difference between dissociation and uncoupling, terms used for seizure diagnosis and detection. And I don't know who wants to sort of expound upon that. I kind of think of those as pretty similar terms, synonymous kind of terms, but.
That's exactly right. In the text, it's essentially used interchangeably. It's just that people may be more familiar. I don't know if you have a different thought, Dr. Westhoff.
No, that's exactly it. I think originally there were some people who would use one of the terms to describe the phenomenon of uncoupling the clinical signs from the electrographic seizure, and otherwise to say that there are still clinical seizures without electrographic signs. But now that we don't really think of clinical only seizures as true seizures, those phrases are used essentially interchangeably.
Cool. And then as we're on the subject of terminology, I think this is a really excellent other question that was asked to clarify terminology. So this person asks if burst suppression on the EEG or the AEEG is equivalent to seizures, and how aggressively should we treat it? What to do if the anti-seizure medication, the newborn, if they give anti-seizure medication and the newborn stays in this pattern?
Sure. The burst suppression is actually the background pattern of the EEG and is not the ictal or seizure related pattern. But as you saw with Milagros's case, it can be a little tricky when you've got seizures during those bursts. But there are very specific criteria from the American Clinical Neurophysiology Society defining what burst suppression is in terms of voltage and interburst duration and things like that, particularly in neonates. Well, in all people, but in neonates, there's also specific criteria. So it's not something we can necessarily treat. I guess what I'd say, though, is that sometimes we see more discontinuity or lower voltages and things like hypothermia, but we're not going to address that by changing our hypothermia. We're just going to allow that to resolve. So the seizures would be the pattern that evolves in frequency, amplitude, and duration, which is the thing one would treat. And the burst suppression, which is that very specific criteria for voltage and pattern in the background of the EEG, is not something that we treat.
Great. Thank you for clarifying that. We have another kind of I love that people are asking like really good basic questions too. This is really awesome. So we have another person who's asked how it's very challenging to differentiate a clonic from a myoclonic seizure. Could you explain that really simply?
Yeah, it's the quality of the movement. And I think it's hard without seeing good videos, to be honest. But I guess what I would say, in my understanding, is that myoclonus tends to be a little bit more irregular and has sort of varied phases to it, whereas clonic tends to be a little bit more regular. And I don't know if other neurologists want to weigh in on that. That's sort of how I understand it.
Yeah, this is a trap because we're being recorded.
Yeah.
So clonic is a quick contraction of a muscle group with slower relaxation, and it's usually at a frequency of about 1 to 3 hertz. Myoclonic is faster than that. It's a contraction of a muscle group, and it could be the whole body, it could be one limb, but it's usually very fast and it's equally quick on the contraction and relaxation. Clonic, like Tiffany said, is rhythmic, more often sustained. Myoclonic could be isolated single jerks or clusters of irregular jerks.
Awesome. You guys are great. And I promise we won't share the recording widely of that. If anything is ever, if anyone ever, comes up with evidence to go against what you said. Okay. So, wow, there's like the questions, there's so many coming in. This is an interesting one. I like the ones that come from different parts of the world. So what's your advice for your first anti-seizure medication if you have no intravenous form of phenobarbital in your country?
I know that's a problem in Mexico in particular. They just don't have it. You use what you got. So I think benzos are a great choice because they're usually readily available. You have some sort of intravenous formulation. And there's data to show that they're efficacious as first-line treatment. There's even some places where it's the preferred first-line treatment for neonatal seizures where phenobarb is available. So that would be my suggestion for first-line drug.
Okay. And I think that we are coming up fast on the 1 o'clock hour here. And so I would like to say thank you so much to both of our speakers, Tiffani McDonough, and I'm not going to say your name as beautifully as you do, Milagros, but Milagros Carusillo, and to our invited expert senior author, Dr. Courtney Westhoff. Please, everybody, collect your CME credit with the code in the upper right-hand corner. And I hope you all have a wonderful day. And thanks so much for coming.
Thank you for the
Thank
invitation.
you. Thanks so much.
Thanks, guys. Bye.
Bye.
Record.